Welcome to this talk on sepsis and septic shock in the pregnant patient. I'm Dr. Julien Villot-Lapointe. I'm an internist and intensivist working in Montreal. I work in obstetric medicine both in the outpatient and inpatient setting, including the ICU. I have no conflicts of interest relevant to this talk, and these are the learning objectives. So throughout the talk, we'll try to review some important maternal and physiological principles relevant to the management of sepsis during pregnancy. We'll build up a differential diagnosis of an infectious source during pregnancy, and finally come up with a specific management plan for sepsis during pregnancy. So first of all, bear in mind that sepsis and septic shocks are still a significant health problem worldwide, and they are currently a third leading cause of maternal death. And there's a great discrepancy between higher and lower income countries, both in terms of incidence and consequences of maternal sepsis. We know that in higher income countries, as sepsis progresses to septic shock, there are still a 5 to 10% maternal mortality risk, which is lower than the general population, but is still very significant. And hopefully this figure will improve over time as there are global initiatives which are trying to improve the prevention, the early recognition, and the treatment of maternal sepsis. In terms of early recognition, this is really key to provide adequate investigations and treatments. And we have to assess for maternal risk factors, identify warning signs, and perform adequate investigation to diagnose sepsis and figure out what's the infectious source. In terms of maternal risk factors, most of maternal sepsis will be related to interventions, so either being cesarean delivery, instrumental delivery, or any other procedures, including abortion, especially non-medical abortion. Medical comorbidities can also increase the risk of sepsis and its consequences, such as cardiac and respiratory comorbidities, pre-existing diabetes, or sickle cell anemia. And there are obstetric conditions which can also lead to sepsis, including stillbirth. If we suspect an infection based on these risk factors on history and physical exam, bearing in mind that fever is often absent in sepsis, we have to look for systemic signs and organ dysfunction. We know that throughout pregnancy, there are changes in the cardiac and respiratory systems, which will lead to an increased heart rate, increased cardiac output, decreased systemic vascular resistance, a mildly decreased blood pressure, and an increase in respiratory tidal volume. So that's why vital signs of pregnancy are a little bit different in the general population, and we'll consider a heart rate potentially abnormal if it's above 115 beats per minute. Hypotension for systolic blood pressure below 90 should still be considered potentially significant, as the blood pressure will decrease just a little bit throughout pregnancy. We just said that the tidal volume is increased during pregnancy, but the respiratory rate is not. So tachypnea is a reliable sign both for the diagnosis of sepsis and for its prognostic significance. Finally, lactate can be elevated solely by a normal delivery, but most of these have shown that values will usually be below 4 millimeters per liter. So any value above 4 millimeters per liter in the right clinical context could be considered significant. Finally, organ dysfunction signs are just the same as in the general population, bearing in mind that often platelets will be lower in pregnancy, just as creatinine. So because of this difference during pregnancy, our scores such as the SOFA or QSOFA score or any other diagnostic screening tools or prognostic tools have not been validated during pregnancy. And there are a few groups which have suggested changes to these scores or new scores, but unfortunately none of them have been really validated to be used clinically. And you might have heard of the MU scores, which is the Modified Early Obstetric Warning Score, which is a score not specific to sepsis, but just for severe maternal morbidity during pregnancy, which can be used institutionally to try to basically screen the woman and identify significant morbidity earlier. As we're working up and diagnosing sepsis, we have to provide prompt maternal resuscitation. And we won't review the details of sepsis resuscitation, but mostly focus on the differences for pregnant women. First of all, as the uterus increases in size, especially after 20 weeks of gestation, it will cause compression of the aorta, but mainly of the inferior vena cava, and this can lead to a decrease in venous return and cardiac output by up to 80%. So certainly to resuscitate a woman who is in hemodynamic instability, we have to relieve this compression. Often this will be done by manual left uterine displacement, which is the quickest and the easiest way to do it, but you can also provide left lateral tilt. In terms of fluid resuscitation, women, especially at this approach term, or if they're affected by preeclampsia, are at high risk of pulmonary edema. So you have to use judicious amount of balanced crystalloids. And as we just discussed, the venous return is affected by the aortocaval compression. So fluid responsiveness tests, which are based on changes of venous return, have not been validated in pregnancy and are potentially unreliable. As we're resuscitating women, we want to defend the mean arterial pressure. We want to treat hypotension. And even though phenylephrine has the longest track record in terms of the anesthesia literature during pregnancy, norepinephrine has been proven safe and potentially more efficacious than phenylephrine. And we know that it's our first-line agent for general sepsis management, and it's the same in a pregnant woman. Although vasopressin has theoretical risk of uterine contraction, it can be used in pregnancy. It is not our first-line agent, but can certainly be added to norepinephrine if we've got ongoing refractory hypotension. Hydrocortisone should be used in septic shock in pregnancy. It is safe. It does not cross the placenta, although it can increase blood sugar in the context of gestational diabetes. And finally, just like in the general population, look for cardiac dysfunction if you got refractory shock, because pregnant women can be affected with pre-existing cardiac disease, can develop either septic cardiomyopathy or even peripartum cardiomyopathy. What should be our targets in terms of resuscitation? Well, we know that in the general population, a MAP of 60 to 65 is appropriate for most patients, and it's basically the same in pregnancy. There are arguments to target the lower MAP, such as 60. As we just discussed, the normal physiology will lead to a decreased systemic vascular resistance, and also a decreased vasopressor exposure could be potentially beneficial, as vasopressors will lead to vasoconstriction of the uterine placental arteries and decreased placental perfusion. At the same time, there are some arguments for a higher MAP if the woman is affected by chronic hypertension, and also due to the fact that we know that the normal placental perfusion is maximally vasodilated. So there is no autoregulation, and the perfusion to the placenta will be directly proportional to the perfusion pressure. As we just said, the use of vasopressors can also lead to vasoconstriction. So there is a point where increased dose of vasopressor might be harmful. So you have to find the right equilibrium between an increased perfusion pressure and vasoconstrictions of the placental arteries. Other targets for our resuscitation are very similar to the non-pregnant population. So you can use capillary refill time. We just discussed lactate, for which the absolute value can be increased during delivery, but usually levels above 4 are still considered abnormal, and a decrease in lactate is certainly a good prognostic sign. Urine output is unreliable during delivery, especially as we are often using uterotonics such as oxytocin, which has ADH effects and will lead to a decreased urine output even in the context of a stable renal function. So these are the changes for resuscitation in maternal sepsis, but we have also to provide effective treatments for the ongoing infectious source. And certainly there are much less data in pregnancy, but there are some data that shows that delays in providing effective antibiotics are associated with worse outcomes. So In terms of figuring out what is the infectious source, it really boils down to what is the timing of presentation. So if you present before delivery in the antepartum period, pyelonephritis, pneumonia, and septic abortion will often be the source of infection. Bear in mind that depending on your geography, malaria and HIV complications can also be very frequent. In terms of microorganism, this will lead to Escherichia coli being the most frequent cause of sepsis in pregnancy overall, followed by strep pneumonia, gram-negative bugs, and Clostridium, especially in the context of septic abortion. Sepsis in intrapartum, so during delivery, is much less frequent, but is usually caused by chorioamnionitis, often by group B strep. And in the postpartum period is the high risk of sepsis. And often this can be caused by more benign infections such as endometritis, wound infection, pyelonephritis, pneumonia, or mastitis. But it is also a period where there's a high risk for severe infection, such as necrotizing infection, abscesses, infected thrombophlebitis, or sacroiliitis. And especially in the postpartum period, gram-positive bugs, such as group A strep or Staph aureus, are very prominent, followed by, again, E. coli, Clostridium, or other anaerobes. So these are some empiric antibiotics recommendations, which you should adjust to your suspected source, to your local flora and resistance risk factors. Bear in mind also that during pregnancy, in the absence of acute kidney injury, often renal function will be increased. So you might want to use the higher higher doses to be sure that you're not underdosing your medications. Most of the microorganism will be covered by a broad spectrum beta-lactam, such as piperacillin, tazobactam, or carbapenem, which will really be the backbone of our therapy. If you need some further gram-positive coverage, either in the context of severe septic shock on postpartum sepsis or gram-positive sepsis that you would be suspecting, you can add either vancomycin or linezolid. If you suspect a fungal source, which would be quite rare, but unfortunately, the safest antifungal during pregnancy is amphotericin B, ideally liposomal, as the other antifungals have been associated with fetal side effects. And finally, if you're thinking about necrotizing infections or toxic shock, you should add toxin reduction antibiotics such as clindamycin or linezolid. This leads me to one of the most important messages of my talk, is to really look for necrotizing infections and toxic shock in postpartum sepsis. And these are cases which there are often delays in diagnosis and which can lead to very bad outcomes, including maternal mortality. And we know that group A streps is 20 times more frequent in a postpartum period due to a myriad of factors, which in group A strep can certainly lead to significant infections, progressive multi-organ failure, and maternal mortality. So that's why you should suspect these infections in any postpartum sepsis, especially in the context of unexplained refractory hypotension or fever, or any signs of discordant pain, which is often present in the context of necrotizing infection. So don't blame severe pain on cesarean delivery or on psychological issues unless you've confidently ruled out a necrotizing infection. In terms of toxic shock, often the presentation will be one of a progressive multi-organ failure with a relatively minor infection, such as mastitis or maybe mild endometritis. And you can have prominent gastrointestinal symptoms and cutaneous signs, which are much less frequent. If you're thinking about toxic shock, think about adding IVIG, which could be beneficial in that context. And unfortunately, no investigation can reliably rule out these severe infections. So not a CBC, not a CK level, not a CRP, not even imaging. So it's very difficult in a postpartum period to differentiate from a normal evolution of uterus, either by ultrasound, CT, or MRI, compared to an early severe infection. So what's the optimal approach? Well, I suggest that you have a multidisciplinary discussion with the obstetrical team, with the infectious disease team, to try to figure out what's the probability of having one of these severe infections. If necrotizing infection, including fasciitis or endometritis, are a possibility, sometimes the safest course of action is to go back in the operating room and try to do an exploration or debridement if need be, to confidently rule out these infections. Also, a key message is if the evolution is not as expected, you might need to go back to the operating room, as these patients will often require multiple surgeries to perform adequate debridement. And sometimes even these can lead to multifocal infection requiring debridements in other areas, such as the limbs, for example. We haven't talked much yet about the fetus, and that is because to have a healthy fetus, you must have a healthy mother. But there are a few key steps you can take to prevent neonatal consequences. And it shouldn't come to a surprise that sepsis in pregnancy can lead to fetal loss, can lead to prematurity, but also placental dysfunction, including a high risk of hypertensive disorders or growth restriction, even after recovery from antepartum sepsis. And certainly, if the obstetrical team is not involved in the care of a pregnant woman, you want to involve them early to provide adequate fetal monitoring. If you're thinking about potential imminent delivery, which is the case in every severe sepsis during pregnancy, you want to provide antenatal steroids. And as we discussed previously, hydrocortisone does not cross the placenta, so won't provide any fetal lung maturity effects. And you should either change or add dexamethasone or betamethasone for that effect. An important message is to deliver only for obstetrical indications. So there is no data that shows that removing the fetus will improve the evolution of sepsis, even though it might make it a little bit simpler. This will lead to fetal consequences such as prematurity, but also maternal consequences such as bleeding or thrombosis. So these are the 5 key messages for management of sepsis during pregnancy. First of all, recognize maternal sepsis and septic shock quickly. Know about the risk factors, which are mainly interventions, and know about the potential signs with the differences in terms of vital signs during pregnancy. Provide prompt maternal resuscitation. Keep in mind that women are more prone to pulmonary edema and that you must relieve aortocaval compression to perform adequate resuscitation after 20 weeks. Administer effective empiric antibiotics, often through a backbone of beta-lactam, but think about gram-positive bugs, especially in a postpartum period. Look for necrotizing infection and toxic shock. Always think about the severe infection in the context of sepsis in the postpartum period. Don't be reassured fully by so-called unimpressive imaging. And really try to reassess that diagnosis very often if the patient is not evolving as planned. And finally, prevent neonatal consequences, mainly by refraining from delivering early, except for obstetrical indications. Hopefully you enjoyed this talk, and if you've got any questions or comment, feel free to reach me either by email or through Twitter, and thank you for joining this talk.